Okay, here's our clinical roadmap. We'll start off with surgical anatomy and physiology, tackle acute emergencies with foreign bodies and corrosives, look at congenital tracheoesophageal fistulas, and then wrap it all up with GRD and Barrett's esophagus.
So, starting with Section 1, Surgical Anatomy and Physiology. Anytime a GI doc goes in for an upper endoscopy, they aren't just looking around randomly. They are measuring strict, precise anatomical distances right from the patient's upper incisor.
And get this, at exactly 15 centimeters from those incisors, they hit a gap that is only 14 millimeters wide. This is the pharyngoesophageal junction at C6, and it happens to be the single narrowest portion of the entire GI tract. Because it's literally so tight, it's the absolute prime real estate for swallowed foreign bodies to get stuck. And unfortunately, it is also the most common site for accidental perforations during an endoscopy.
Now, as the esophagus travels down, it has to actually pierce the diaphragm to meet the stomach. To remember these levels, just use this classic rapid-fire mnemonic, I ate 10 eggs at 12. I for IVC and phrenic nerve at T8. Ate 10 eggs reminds us that the esophagus, vagus nerve, and left gastric artery pierce the diaphragm exactly at T10, and that 12 is for the aorta and thoracic duct at T12. Easy to remember, right?
What's really fascinating here is how normal anatomy dictates major surgical intervention. Notice that the esophagus completely lacks an outer serosal layer. That actually makes the submucosa its strongest layer. Plus, the lymphatics run longitudinally inside that submucosa. This means cancer can easily jump and cause skip lesions further up the tract. Because of this, surgeons are literally forced to take a massive 10-centimeter proximal margin during esophageal cancer surgeries. That's the highest margin requirement in the entire body. We also have the left gastric artery, which is the culprit behind Mallory-Weiss tear bleeding, and the left gastric vein, acting as the highway for liver metastases and portal hypertension varices. Oh, and as we age, we develop presbyosophagus, which is just an increase in those useless, non-propulsive tertiary peristaltic waves.
Okay, sharp transition here. Let's leave normal anatomy and jump right into acute trauma and emergencies. What exactly happens when things get stuck, or worse, when patients swallow something corrosive?
First up, foreign bodies. Let's say a kid swallows a coin. We have to urgently figure out if it went down the respiratory tract or the GI tract. A tracheal foreign body is going to cause stridor and breathing difficulty, and on an AP X-ray, it sits sideways in the sagittal plane. But if it's in the esophagus, you'll see dysphagia, and the object sits flat in the coronal plane. On a lateral X-ray, the trachea is that anterior air shadow, and the esophagus sits right behind it. Now, there is one massive exception where you do not wait: button batteries. If a child swallows a button battery, it mandates immediate, urgent endoscopic removal. No debate. Even if it successfully passed that narrow C6 junction, these things disintegrate and cause a rapid, fatal perforation.
But what about liquid corrosives? Here we hit a fascinating pathological paradox between alkalis and acids. Alkalis cause saponification. That means they literally melt through tissue, penetrating dangerously deep into the esophagus. Acids, on the other hand, cause rapid coagulation and fibrosis, which kind of limits their deep tissue penetration. But there is a catch. Acids induce pylorospasm. The exit to the stomach tightly clamps down. This traps the acid inside the stomach where it just pools, leading to a much higher risk of severe secondary gastric damage.
So the crucial point here is how we manage these corrosive emergencies without making them worse. First, fluid resuscitation and pain control. Second, and this is an absolute non-negotiable contraindication, do not blindly insert a nasogastric tube. The tissue is like wet tissue paper. You will cause a perforation. Third, another strict rule, no prophylactic antibiotics or steroids. They don't help here. Finally, you have to do an early, skilled endoscopy within a strict 48-hour window. If you wait longer than 48 hours, the tissue becomes too weak, and you drastically increase the risk of an iatrogenic perforation.
All right, leaving the trauma bay, let's shift our focus to the neonatal ICU. Let's look at congenital defects that instantly threaten a newborn's life right in the delivery room. Tracheoesophageal fistulas, or TEFs. This happens when the esophagus and trachea fail to separate properly in utero. Type C is by far the most common variant. This is where the upper esophagus ends in a blind pouch, while the lower esophagus connects directly to the trachea. You'll suspect this in a newborn who has excessive drooling, a maternal history of polyhydramnios, or if you try to place an orogastric tube and it just coils up in the chest. To diagnose it, we use a contrast study with iohexol.
But here is the critical clinical pearl for you. You absolutely must actively hunt for VACTERAL anomalies. That's vertebral, anorectal, cardiac, TEF, renal, and limb defects. And watch out, because those cardiac abnormalities are the most common and the most fatal.
So how do we fix the type C fistula? Surgeons perform the Cameron Heights procedure. It starts with a posterolateral thoracotomy to get into the chest. Then, the surgical team carefully takes down that abnormal fistulous connection, repairs the hole in the trachea using an absorbable PDS suture, and finally, they anastomose or stitch together the two separated ends of the esophagus. It is an incredibly delicate plumbing fix on a tiny, fragile infant.
But, despite flawless surgical execution, I have to give you this somber statistic. The overall mortality rate for infants with these tracheoesophageal fistulas remains stubbornly high, hovering right around 40%. This is largely driven by those severe associated conditions we talked about, particularly the cardiac anomalies from the VACTERAL association, alongside severe pneumonia from aspirating gastric contents straight through the fistula.
Okay, we're going to pivot now from rare congenital defects to an incredibly common chronic pathology that millions of people deal with every day. Section 4. Gastroesophageal reflux disease, or GERD. This is what happens when the physiological high-pressure zone of the lower esophageal sphincter just completely fails.
And this brilliantly illustrates a vital concept in clinical medicine, the difference between the most practical test and the ultimate truth. For GERD, the investigation of choice, like your standard first look, is an upper GI endoscopy. It's practical and shows immediate structural damage. But the true gold standard, that's 24-hour pH monitoring. It gives you 100% diagnostic accuracy, and it is strictly required before you even think about surgery. Just remember, you've got to tell the patient to stop their proton pump inhibitors 5 to 10 days before the pH test. If they don't, you'll get a false negative.
During that 24-hour pH monitoring test, the computer is calculating something called the Demeester score. And if that final number comes back greater than 14.72, you have definitively, mathematically confirmed the diagnosis of GERD.
So what happens when lifestyle changes and PPIs just don't cut it? We turn to surgery, specifically the Nissen fundoplication. The main physiological goal here is to pull the esophagus down and restore its intra-abdominal length to greater than 2 centimeters. Ideally, we're aiming for 3. First, the surgeon tightens the diaphragmatic crura to close that wide gap. Then they mobilize the fundus of the stomach. They pull it back and forth behind the esophagus in a motion literally called the shoe shine maneuver. This makes sure the whole thing is completely tension-free. Finally, they wrap that stomach tissue a full 360 degrees around the lower esophagus and stitch it in place, creating a really powerful new anti-reflux valve.
But there's a well-known catch to that total 360-degree Nissen wrap. While it is highly effective at stopping acid, it is totally notorious for causing gas bloat syndrome. The wrap is so tight, the patient literally loses the physical ability to burp. Because of how distressing that complication is, many surgeons opt for partial wraps instead, like the Door 180-degree or the Toupette 270-degree wraps. These leave the valve just a little looser, which significantly drops the risk of gas bloat while still managing the acid reflux.
Moving into our final phase, Section 5. What exactly happens when severe GERD goes completely unchecked for years, constantly bathing that lower esophagus in harsh stomach acid?
You get Barrett's esophagus. This is a defensive metaplasia. The normal squamous epithelium actually transforms into columnar epithelium just to survive the acidic environment. If you look at it on an endoscopy, it looks like this angry, red, velvety mucosa. But here's the key. The absolute defining, non-negotiable requirement for this diagnosis is finding specialized intestinal goblet cells on the biopsy. If you see goblet cells in the esophagus, you have Barrett's, and unfortunately that carries a direct risk of esophageal adenocarcinoma.
Now, sometimes this abnormal mucosa isn't perfectly obvious to the naked eye, so to hunt down these dangerous microscopic changes, GI docs perform chromoendoscopy using methylene blue. Just like how acetic acid highlights abnormal tissue on a cervix, methylene blue preferentially stains this abnormal intestinal metaplasia right inside the esophagus. Once those blue patches are highlighted, the doctor takes strict, aggressive 4-quadrant biopsies exactly every 1 centimeter. You have to ensure no cancerous changes slip through the cracks.
Let's map out the Seattle protocol and see how this builds into a really aggressive management strategy. If the biopsies only show simple metaplasia, you do an endoscopy every 2 years. But if the cells mutate into low-grade dysplasia, you immediately burn off that abnormal tissue with radiofrequency ablation, or RFA, and you scope them every 6 months. High-grade dysplasia, you ablate it and aggressively scope every 3 months. And if outright cancer develops, the timeline is immediate, and esophagectomy is required. Also, be hyper-aware of a tricky clinical trap post-RFA known as buried glands. Sometimes, the ablation allows normal squamous tissue to grow right over the top of surviving Barrett cells, literally hiding developing cancer underneath a healthy-looking surface.
I want to leave you with a final, provocative clinical scenario to really test your diagnostic instincts. Imagine a 75-year-old patient walks into your clinic with brand new onset GERD, difficulty swallowing, and unexplained weight loss. Do you casually start them on the standard PPI empirical trial, or does the classic algorithm break down? The answer is, classic algorithms go completely out the window when red flag symptoms present in the elderly. You aren't treating simple GERD anymore. You are aggressively ruling out esophageal cancer. Never let common algorithms blind you to obvious red flags. And that wraps up our fast-paced mastery of the esophagus. Stay sharp out there, and I'll catch you on the next explainer.